Hello and welcome to episode 5 of Safe4F Stories podcast. I'm Laura Gaisley, Integrated Access and Flow Manager and Safe4F Lead. Today I'm chatting with Dr. Kenneth Rockwood, Professor of Medicine, Geriatric Medicine and Neurology, and Clinical Research Professor of Frailty and Aging at Dalhousie University. Since 1991, he has been a staff physician at Nova Scotia Health and Senior Medical Director of Nova Scotia Health's Frailty and Elder Care Network since 2021. Throughout his distinguished career, Dr. Rockwood has earned many awards and honors, too many to list here. We would definitely need a separate podcast episode for that. But just to name a few, in 2023, he received the Medal of Honor from Canada's Health Research Foundation for pivotal contributions to health science. In 2021, he was awarded the Ryman Prize International Award, awarded annually for the world's best discovery, development, advance, or achievement that enhances quality of life for older people. Most recently this year, he received the Canadian Society for Clinical Investigation's Distinguished Scientist Award for significant contributions to knowledge at the forefront of research endeavors. As you can see, Dr. Rockwood has a deep understanding and specialized insight into frailty. For those currently implementing Safe4F, you'll know that the second F, or the small f, in Safe4F stands for frailty. So today we'll take a deeper dive into frailty with Dr. Rockwood and discuss how it relates to Safe4F. So, Dr. Rockwood, welcome and thank you for joining me on Safe4F Stories. Also, congratulations on your latest honor, the Canadian Society for Clinical Investigation's Distinguished Scientist Award.
Yeah, I think we can take it as a general prompt to just move along now, son. Right?
Yeah.
But anyway, no, I am glad for it.
Great. So let's dive into the topic at hand, which is frailty. So, what is frailty? What is the definition, and what are the signs?
So frailty is a state of increased risk that arises with aging. Younger people can have it, but mostly it's pretty tightly associated with age. And the risk comes from many places, but mostly it comes from aging. So the question is, what is aging? So it turns out that aging at the level of a gerontological definition refers to the population statistic of an increase in the risk of death for the group. And that's why, for example, we don't talk about people starting to age the minute they're born, because the risk of death when you're 30 minutes old goes down across time, and that for the group as a whole, it goes to about age 15, and then it starts to increase a bit more in men than women at the start, the so-called testosterone toxicity. And then across the life course will increase. And a really important way that this is related to what we're seeing right now in healthcare is that at the age of 75, if you were to plot out the risk of hip fracture or the risk of congestive heart failure or the need for transplantation or dialysis or any range, large number of things that are late life illnesses, they all start to really accelerate at the age of 75. So in 2021, the leading edge of the baby boom began to turn 75. And what we're seeing right now was made even worse by the intervening pandemic. And what that did was it hit at a time in which the burden was going to increase anyway. And what we're seeing right now still has some of the hangover of COVID, but what we're seeing right now is the very start of population aging. And what we see when people are frail, they've got more than one thing wrong. And so we're seeing in the emergency department right now, people coming to the hospital with more than one thing wrong at a time in a system that has succeeded for 50 years or more by ever greater specialization. And so we've gotten really, really good at people with one thing wrong at once. And in fact, the data are very clear. If you're going to have a particular operation, far better to go to a place where they're doing a few of those every day than when they might be doing one every few months or so. So we know that there is a lot to be gained by expertise in the one thing wrong at once. What's happened, however, due to complex reasons, including financial, is we've denigrated the skill set needed to look at someone who's got a bunch of things wrong all at once. particularly because when they're old, they're less compelling, and we've taken over. Well, that's what happens with old people, but it's not. It's what happens with the subset of older people who have these multiple problems that interact commonly with social issues, and that multiple subset is the people who are frail. So frailty is a formally complex state of increased risk from multiple risk factors that go along with aging.
Perfect.
And the other thing to know about aging is that aging is a series of events, one or two dozen or so distinguishable groups of events that happen at the level of cells and subcellular processes, molecules and protein. Well, molecules a little bit, proteins definitely. And most of this comes from intrinsic damage that with age goes unremoved or unrepaired. So what happens, this is the view of frailty that we have taken, is that as people age, they accumulate more healthcare deficits. And these start at the level of the subcellular processes, but they scale up to affect the individual at the level of a bunch of different systems. By that I mean, the heart system, the kidney system, and such. Therefore, when that person gets acutely ill, their ability to respond to that acute illness is not as good as it was if that had happened when they were younger. And so that's where we get in this paradigm problem, because a lot of the success that people are justly proud of who are subspecialists is their ability to really fix illness in someone with that one illness wrong, typically a younger person, and they're better thereafter, or they're cured even. And that's not what we have when we see older people with a single illness. And so for a large number of understandable problems, we're not coping as well with this. What's happening right now, for the first time in my experience, is that we have a system that is now taking seriously the challenge of frailty and looking at ways to treat frailty that are not focused on a single discipline. Is that fair?
Yeah, absolutely. So this leads me into my next question, which is about the frailty scale, which I think speaks to how we're treating some of this. So there is a frailty scale. So can you explain what it is and how to use it?
Sure. The clinical frailty scale is a 9-point scale that was originally developed to summarize a quite intensive assessment process called a comprehensive geriatric assessment, which is the major technology of geriatrics. And is not, unfortunately, assessment is a terrible word. It's, pity we couldn't go back 50 years and change it, but that's what we've got, because people confuse it with an assessment by continuing care for what degree of home care you need. And instead, it was meant to replace the term diagnosis. So it got people away from a single diagnosis and tried to understand everything that they needed in order to get home. So the geriatric outcome is being alive and in your own home 1 year after whatever event you had as a result of this assessment, and that the assessment is the care plan that followed from that. And unfortunately, what's happened is that the integrity of care planning for people with many things wrong all at once has been undermined by understandable pressures to get on with it, pick this one thing, and so on. But we work in a hospital system where the performance of the hospital is judged by how well we do with what of all these things someone has wrong with them. A person says, well, that's their most responsible diagnosis. That's really why they came. But that's quite arbitrary. And so we're seeing mismatches right now just based on administrative understandings. But more fundamentally, we're actually seeing what happens when you don't know how to look after people with many things wrong all at once. And it's very uncommon for people to say, gosh, I wonder why they didn't teach me in medical school how to look after these patients. Instead, they say, well, these patients shouldn't be here. Well, okay, maybe it was 1 in 15. You could understand there might be somewhere else. But if it's half the people that you're seeing, then the problem isn't theirs, it's yours, right? So, and in this case, ours. Our problem as a healthcare challenge as a healthcare system is we got to get better at looking after people with many things wrong all at once, period. And that's what we're aiming to do with the Frailty Elder Care Network. So we said, let's start with the lowest low-hanging fruit. What is the thing that you could best do that would change outcomes of older people who live with frailty? And the answer is clearly early mobilization. Get them up, get them moving, get things going. And for all kinds of reasons, including really groovy, molecular events that arise when you have someone from a supine posture to an upright posture, that will get you good outcomes for the most part. And so we said, let's start there. And we also use that as a way to sneak in the clinical frailty scale. So I have actually gotten back to the question you asked me. And I picture's worth 1,000 words. So if I may, I'm going to hold this up to the camera. And there's the clinical frailty scale. That's the front page, and there's the back page. And you can see it's got words and pictures. And it's meant to be very useful. We have to guard people in our training, we guard people against, don't just look at the picture. And we're going to reform things a bit so that the pictures overlap, so that some people with one of the wee icons, like here, for example, they could be, the icon for 3 can be mixed with 4 and can even be mixed with 5, depending on the circumstances by which people came to the problem. So we're trying to get that idea across. But there are grades of frailty. Frailty is not all or none. There are degrees of frailty. So we have people with very mild frailty who are just at the point when folks are starting to notice there's a little, they're not quite as fit as they used to be. Where I come from in Newfoundland, and where I grew up, it snowed. That's how old I am. It snowed a lot. And there'd be not uncommonly a point during the winter in which the prudent person, and it was man those days, prudent man would go up and shovel the snow off his roof. And when someone got to the point that they couldn't do that anymore, it's like, so like they're still vigorous and such, but it's not quite the same. So it's very mild, very small differences like that, and a few other things. That person can be very mildly frail. Someone's very severely frail when they're typically in bed. They're lying in bed all the time, and they're spending most of their time asleep when they're there. And the farthest they get from their bed is to the commode at the bedside. And generally that's associated with dying. And dying in frail older adults is not a dramatic thing like you see on TV or the movies. No one gets shot and falls over. They just gradually fade away. And so, but both those people would be called frail if we were just to say frail, not frail. And they have completely different needs, completely different prognoses. But they have in common age-related processes affecting multiple systems all at once, some of which have reached disease status and some of which have not. But their ability to respond to an insult, an illness or, stubbing your toe and whatnot, that has gotten worse with time. My brother is an orthopedic surgeon, and he would talk about it in terms of, this man is at the point right now where it'd be a high risk for a haircut. So much less orthopedic surgery. So we need to recognize their grades of frailty and then develop care plans that will meet those needs.
Right. So as you've said many times, and I understand, frail patients have complex needs that do take time to address. So why do you think it's important to include frailty in the SafeRef patient flow medicine bundle?
So what SaferFlow is trying to do is to get more people through the system quicker, but also trying to get more people with the needs that are, with the care that's appropriate to their needs. Sometimes for people who are frail, it means doing more because they're at a higher risk for an adverse outcome. So you got to kind of step things up a bit. Sometimes it means backing off because they will not withstand the procedure you have in mind for a younger person who only had that thing wrong.
Right.
But most often it means doing things differently. You can generally, for most grades of frailty, you can do most things that you need to be done, but you may have to do them a bit differently than you would have otherwise. But the other thing, and St. Augustine famously told us that you've never really mastered a topic, because that's how long ago that was. People would master things. Now you never really become a real expert in a topic till you've learned its hard teachings. And the hard teachings, and there are many hard teachings in frailty, but one of them is that you must meet people where they're at, and you have to sort out what it is they need to get home. So what the F in SaferF does is it encourages us to ask the relevant and non-arbitrary questions, as opposed to the raft of stuff we're supposed to tick boxes about. The relevant and non-arbitrary questions, which are these: what was this person like before they got sick? right? People come to the hospital and there's sort of a general understanding, I like to call it the implicit contract, of what's going to happen. They're going to get better. That's why people come to the hospital. So what does better mean? So very few people, in my experience, ever think of better as being some far gone state. You know, when they won the hockey tournament for the high school and so on. They have a very focused understanding. There's a thing they want to get back to, and so we need to know what the baseline level of frailty is, and then we also need to negotiate with them and their care partner. If we got them back to that state, could you take them home? And if so, now everybody understands what it is we're driving for, right? And that would be a revolution in hospital care. I mean, very often we've gotten used to, well, you came in with pneumonia, you know, your white cell count is down now, your temperature is down, your cough is still a cough, but it will be for a while. Your chest X-ray won't change for a few weeks, but it's time for you to go. Why is that? Because that's what the Canadian Institute for Health Information says. You stay for 3.5 days. But if this person could walk before they came in and can't walk now, that's nothing bad they've done, right? We're beyond the demonic possession era, right? And we're looking at what has happened with this person. They've become deconditioned. How come? It's not because there's disuse. It's because it takes a lot of energy to maintain the strength in these set of muscles we call the hip flexors, which is what you need to stand up and get out of bed, right? And so we need to have that disciplined, focused, science-based understanding of what it is we are seeing, and get away from moral language about, oh, you know, good, bad sort of stuff. We should be able to describe fairly precisely what is happening there. So that's why we started with mobilization, because it integrates a huge amount of information, right? In order for you to get out of bed, you've got to have most things hooked up, right? Like the brain's got to be working pretty well. The nerves that go out to the muscles got to be working pretty well. The muscles got to be working pretty well. The sensory information you have going back to the brain about where you are in space, is your arm up or down, and so on, about how it is you have a coordinated movement that you do without thinking. Although you got to think about it now, because it's actually harder now that you have to compensate. Your heart's got to work well enough to keep the blood flowing. You got to be able to have a good oxygen saturation from your heart and your lungs, and so on and so on. You have to have all these things that are integrated to work well. So when we see that not working well, we realize there's a problem. So part of what we're trying to do with the mobilization initiative is to show people what better looks like in the hospital. Now, you know, experienced doctors and nurses have an intuitive understanding of this. We've actually been able to break it down into predictable changes in mobility and balance, so we can put a number on. And I don't shy away from talking about numbers, right? If you can't measure something, it's very hard to manage it. So this allows us to track things. And so we're trying to show people that the joy of geriatrics consists in knowing how these things work and being able to make the small observations that before you might have had as a gut instinct, that now you can say with precision, this person was a 2-person hands-on assist 3 days ago. They're an independent assist for transfer right now. And we would predict that they're going to be able to walk well enough to go home in 2 days. Like that would be a plausible scenario of things. Right. But at the same time, if you said this person was an independent assist for transfer yesterday and they're back to 2-person hands-on, the chances are very high there's something wrong, something going on, right? And so that means you need to check them out for the common things that befall older people in the course of their recovery from acute illness. And so we started with the mobilization because it allows people better to see what a geriatrician sees when we look at someone who's ill. And we know that there are never enough geriatricians to go around. Like this is not something we just download there. I think there's 14 of us right now in the province. Though we're recruiting heavily and we're getting more all the time. But still, what our job is to be catalysts, is to help the system see what we see when we see a frail older adult. And I'll stop there.
Perfect. Thank you so much. So any advice to units that are learning about frailty and SAFER-F? Anything else you want to add to what you've already spoken about?
I would add a couple of things. One is the Frailty Elder Care Network has resources available. We've got stuff that is now just about to go up online, videos and jazz like that. And there are, I confess I don't know the terms of art. Everyone would recognize in terms of where you get a video and how you tick the box and such. But I strongly encourage people to get involved in that, to look at it, to talk to their peers about this. Everywhere we go in the province, there are frailty champions. There are people who really have bought into it. So if you're having trouble in a particular area, there's someone 100% guaranteed, there's someone in your hospital who can help you with it. And the thing I'm also encouraging is for people who are starting to discover for themselves the joy of geriatrics to share that joy and to start to work with people and ask the questions about how you do this. My dad used to say there's a proper way to use a pick and shovel. So there's a proper way to do everything. So learn all the stuff, the proper way to transfer, the proper words to use, the way to communicate information, the ability to listen to anybody who can talk to you about how things might have changed, particularly family members. They know the person best, right? So these are all the things that we need to do. And the final thing I would say is that we recognize at the Frailty and Elder Care Network and with Access and Flow, we all understand that people have knowledge needs, and they also have to have a way to use the knowledge they've got, which is kind of to recreate it, to jazz it, right? And some of these things will be picked up very easily by people. Some of the things are a bit trickier, but we've got to up the general understanding of how this works if we're going to provide publicly funded healthcare with the good outputs that it is capable of. And we know that we can't just do that by telling people stuff or sharing knowledge and stuff. Geriatrics is way more, and frailty informed care is way more than a good set of attitudes. It's a skill set. But it's very hard to take that skill set and use it and to be allowed to use it in the ward where you work if there isn't the good attitude that goes with this.
Yeah.
And no one went into healthcare to be evil, right? But what's happened is they develop patterns that they're comfortable with, and they see other things as being at risk. And a lot of what we're seeing in terms of some of the friction around this is the risk amongst members of a team about, is it safe to do so and so? And safety is obviously going to be a big concern, but we also know that safety can be a crutch, right? And we also know in healthcare that we're not good in healthcare at disputes with people. We tend to personalize things way too much, and we tend to use language that has nothing to do with the observations that we have made. So we need to make precision to be precise in our observations, and we have to have non-punitive ways to share. We got to get to the passive-aggressive behavior, crossing your arms, rolling your eyes, and yes, the big sigh. We have to get rid of all of that. We need to replace it with the respect and the proactive way of conducting your care that will make your care better and that the people that we're trying to care for deserve. And so we've got a program called the Dignity of Risk, and we've got a couple of just fantastic folks who I've sadly recruited out of the clinic where I work, and we're making them available across the province. Catherine Hominick is a social worker. Catherine Ann Murray is a community occupational therapist. And they have a really good understanding and use much better words than I do in terms of being able to talk about this, about how people can learn to be happy, learn to be joyful in the care of older people who are frail, especially when they're acutely ill. And that is how we think that's what we think the key is to improving flow, is that people have a better sense of what they're doing. They bring about the enthusiasm that goes with that. We develop the resources that we need to match the care plans that we're trying to put on offer. And we see better outcomes arising from all of that.
Perfect. Thank you so much for your time, Dr. Rockwood. I appreciate it. And just for anyone listening, I will ensure links to the Frailty and Elder Care Network, as well as the Dignity of Risk resources, will be included in the comments for this video. So today I was talking to Dr. Kenneth Rockwood about frailty and SAFER-F. Dr. Rockwood is a professor of medicine, geriatric medicine and neurology, and clinical research professor of frailty and aging at Dalhousie University, as well as Nova Scotia Health's staff physician and senior medical director of the Frailty and Elder Care Network. Thanks everyone for listening to episode 5 of SAFER-F Stories podcast. Please like and subscribe to catch upcoming episodes on the SAFER-F YouTube channel.